for delay, and I'll try to sum it quickly. So it's a potpourri of whatever is not covered so far. I have no financial disclosures, and all the work I'm presenting here has been done at Arvind Eye Care, Madurai. So there are two kinds of miscellaneous retinopathies. You can say you can have an uncommon presentation of a typical vasculopathy like PDR, CRV, or macular telangiectasia, or you can have an uncommon vasculopathy per se like preeclampsia versus retinopathy, Coats disease, or cavernous hemangioma. But why they need surgery is for routine reasons like epiretinal membrane, a macular hole, but sometimes the indications themselves may be complex like a macular hole within a tractional detachment, submacular exudates, or vitreopapillary traction. So like this patient came to us with the post-PRP developing a macular tractional detachment with macular hole in the left eye. Now this patient vision had gone down from 636 to 260, and if you look at the hole carefully, it was an oval stretched hole. And if you look at the configuration of the detachment, typically when the hole occurs in a TRD, it converts a TRD into an RRD. It's called a combined mechanism detachment, and it becomes convex. Here it remained concave, and therefore we thought that it is a traction which is the main element. We did not address the macular hole at all, and just did a routine surgery as we do for a macular TRD. We got a closure of the hole, and which remained closed after the removal of the oil, and the vision improved to 6/36. But there is a more interesting case of supposed diabetic who had disc and macular edema with a florid NVD, apparently florid NVD. Now the catch was that the fellow eye had a mild NPDR. So when we did an OCT, we found that his macular edema was actually more focused on the nasal side with the macular detachment. Now flow-seed angiography really confused us. The NVD, which was so obvious on this, they did not leak at all. In fact, you could see the silhouetting of the vessels in the late phase. There was no macular edema, there was no macular leakage. And if you look at the hemorrhages, they are more like a hypertensive hemorrhage than actually the hemorrhage of diabetic retinopathy, and there are no capillary dropout areas. We chose to follow up the patient. Now 3 months later, his vision dropped to 6/36. But surprisingly, if you look at the OCT, from the previous slide, you can see that actually the macular detachment has actually subsided, and the traction of the macula has got relieved. Now what has changed is the disc edema had become many times more, and surprisingly there was an RAPD. So this is the first case of diabetic tractional papillopathy we diagnosed, and we told the patient that you have got vitreopapillary traction and discussed the surgical option. I told the patient that I haven't operated this kind of case before, but it is a very simple surgery consisting of only vitrectomy and PVD induction. After PVD induction and vitrectomy, this disc was regressed, the disc contour restored, and the vision improved to 6/6. We have a follow-up of 1 year, we published in Eye. So vitreopapillary traction is an entity which has been described by Kroll et al. In case of PDR, we are the first to report in NPDR. Now we have one more case in which there was an ischemic HRVO with a florid NVD. We did PRP in this patient, got a massive TRD with similar oval hole. Again, we didn't do ILM peeling, and we were able to close the hole with a good recovery of vision. Our fourth case was a case of macular telangiectasia with a routine lamellar macular hole, which are known to occur in macular telangiectasia. His vision was 6/9. After more than a year, however, he developed a full thickness macular hole with a loss of vision to 624. Now the conventional literature till that time, mainly a bigger study by Charbalisa, said that vitreomacular traction does play a role, but macular hole surgery has poor results. However, the contours of the macular hole look very much like a typical idiopathic macular hole, and therefore I continued with the surgery, and we got a good result of 6/9, and we published this. And we conclude that it is the shape which is more important, not the cause of the macular hole, because the Charbalisa study, if you see the black and white OCT, they were atrophic moth-eaten edges, unlike our case, which had edges more typical of idiopathic macular hole. Now this is one of rare cases. There is a 22-year-old female, a primipara. She developed a severe visual loss in both eyes to 1/60 at term pregnancy, followed by a stillbirth due to preeclampsia after 12 days. She had no history of trauma or any systemic disease, no systemic bleeds, ruling out DIC. Her anterior segment was normal, and she had no RAPD. On flow-seed angiography, we saw extensive capillary dropouts, and more importantly, there was leakage from the disc and the vessels. There were macular detachments in both eyes, along with foveal atrophy in the left eye and a macular hole again in the right eye. So we gave an intravitreal transdermal in the left eye and advised vitrectomy for the patient. However, she returned only after 4 months. So the vision had improved to 612 on the left, but she got a TRD, which we operated this time with the ILM peeling, and got a good recovery. So the reason for giving IVT in the left eye was the inflammatory pathology, and we got a good result with that. Now, there's a case of cavernous hemangioma actually. Now, cavernous hemangioma are typically known as benign static tumors. But we got a case in which the patient complained of progressive visual loss. It is diagnosed typically by the clinical picture and on angiography by the cluster of, by the capping of the dye due to a clear plasma interface above and RBPCs below. We did a vitrectomy for this case. I am showing the injection of translucent dye. Now, what is to be noted is the PUD induction, just like vitreopapillary traction, has to be very gentle, because otherwise you can get a massive bleed from the this sacral aneurysms. So after the PUD induction, the rest is easy. We did a double staining using a trypan blue dye first under air, followed by BBG dye to remove the residual ILM. So this is the ERM being removed, followed by ILM removal, which I will skip. Now the important thing to stress here is, this is the ocular part of the management, but the systemic part is equally important. These are the patients who are at the risk of fatal cerebral aneurysms, and therefore, especially when retinal lesions are present, we must do an MRI of this patient even if they are systemically asymptomatic. So this is one rare situation where ophthalmologist has a big role to play. And similarly, we should do a family examination because it's an autosomal dominant condition. We published this last year in BGO. The final case is that of a Coats disease with massive subretinal exudation. Now, typically, if this case don't have detachment, we don't have much to do. However, we injected avastin because a young patient. The patient had some recovery of the heart exudates, but the peripheral telangiectasia and detachment persisted. We followed up with a half-dose IVT and laser, which got further reduction in heart exudate, but still the peripheral telangiectasia persisted. But it increased further. After 3 months, we did a cryo along with the scleral buckling and fluid drainage. And this patient, you can see that there is a dramatic recovery of the macular heart disease with a visual acuity of 612, and multimodal modality achieved dramatic results. So what I want to conclude is, even unusual vitreoretinal maculopathies cause visual loss by common mechanisms. We have to focus on the cause of visual loss. The knowledge of the disease helps in tweaking the technique, and success depends more on strategy than on skill, like addressing the macular hole with morphology rather than with the etiology. And visual outcomes can be good if it is well planned and reasonably executed. Thank you very much.